Thanks very much, Hasbullah, and I'm honored and really pleased that you invited me, and thanks also to Palak Sono. It's a pleasure to be here. Can you hear me properly? Is this working? Okay. So my presentation is going to focus on monitoring universal health coverage, and I'll give you more sort of a global flavor of some of the work that we're doing. And before I go on, let me just introduce myself. I'm Ajay Tandon, and I'm actually the lead economist for the East Asia and Pacific region at the World Bank, and I'm based in Washington, D.C., currently on mission here in Indonesia. Let me begin by looking at the definition of UHC again. I know you've all been sick and tired of listening to the UHC definition, but it's important here because I'm going to focus a little bit on monitoring. So in order to understand how to monitor UHC, we have to sort of parse out the definition. There used to be an earlier global definition. I think this was around 2005 when initially this whole UHC revolution sort of started, and that earlier definition was very simple. It was about ensuring all people receive all the health services they need without suffering financial hardship. And then it was revised a couple of years later because there was this perception that universal health coverage was only referring to curative care. So in order to make it very clear that UHC was not really only about curative care, there was, I think this was Raymond, this is WHO, I think, that redefined it very carefully. And the redefined definition was ensuring that all people can use the promotive, preventive, curative, rehabilitative, and palliative health services they need of sufficient quality to be effective, while also ensuring the use of these services does not expose the user to financial hardship. So this is not just a trivial change, it was really a change in how UHC was to be conceptualized and to be monitored as well. So this definition change is quite critical. I think it's notable, just to make some points, that what sets this UHC agenda apart from some previous global health objectives, and one of the previous speakers referred to Alma Ata and the Health for All, is this really explicit incorporation of this financial protection objective of seeking health care. And you know, UHC is really about progressively reducing not just the burden of disease, but also the economic burden of disease. So I think this duality is very important to keep in mind, that this is sort of brought to the fore by this new movement towards getting at universal health coverage. And so increasing effective coverage of health interventions and increasing financing from prepaid pooled sources and reducing financing from out-of-pocket spending sources is really key in order to make progress towards universal health coverage. I'll move to the next slide. This is sort of a interesting reminder to us as health economists that, you know, consumption of healthcare is different from consumption of other products. And we often use this sort of a semantic thing to say that there are 4 U's in health shocks. So first of all, health shocks, that means when you get ill, they're unwanted and undesirable. So unlike, for instance, the demand for bananas or for Coke Zero, you know, nobody chooses to check themselves into a hospital if they could help it, unless, I guess, if you're a hypochondriac. The second U is that health shocks are uncertain and unpredictable. So normally you're not able to predict with certainty when it is that you're going to fall ill or require hospitalization. The third U is health shocks are uncommon, and this is actually quite an important aspect of understanding consumption for healthcare. By uncommon, I mean usually not everybody in the population falls ill at the same time. So it's only a relatively small share of the population in a given year or in a given time period that ends up needing to be hospitalized or needing healthcare services. So we have, you know, unless of course you're hit by an epidemic or an influenza epidemic, when everybody tends to or a large section of the population tends to fall sick, this third U is actually very important. It's not that everybody doesn't get sick at the same time. And the fourth point is the point I was making earlier, that there's this recognition that when you fall ill, it's not that you're falling ill alone. It's also you're hit by both a health shock and you're hit by a financial shock. So health shocks don't occur in isolation from a financial shock, and this financial shock could be caused by your needing to pay out of pocket for seeking health care. But I'm also referring to what we in WHO used to call direct costs, the indirect costs of illness. That is, you may not be able to work, you may lose wages as a result of that, and so on and so forth. Absenteeism that's related to illness. So this universal health coverage definition really explicitly brings this duality of the health shock and financial shock up to the forefront, and some of these characteristics of health, the health sector, are what make these amenable to financing from prepaid pooled sources. Basically, prepaid pooled sources meaning some form of tax financing or social insurance or private insurance. Since I guess since the early 2000s, more than 100 countries globally have either claimed to have attained universal coverage or have made explicit commitments to getting at universal health coverage. These are just some examples I've put up. Korea in 1989 claims to have attained universal health coverage for its population. The next in line is Thailand, within 2002 claims to have attained universal health coverage. Next is the Philippines. It claims to have attained or will attain universal coverage in 2016, and Indonesia 2019, as you know. Vietnam is 2020, about 80% of the population is their target. India 2022, Laos PDR 2025, Myanmar 2030, and Bangladesh 2032. And it's interesting, you may note there's actually an income gradient here, as these are sort of ranked by GNI per capita in terms of also their how they're committing in terms of the timeline for attaining universal health coverage. Also important to note, and I think this was also noted by one of the previous speakers, that universal health coverage is an explicit objective of the Sustainable Development Goals. It was not there in the Millennium Development Goals. It's now explicit in the Sustainable Development Goals, and it's SDG 3.8, which calls for achieving universal health coverage, including financial risk protection, access to quality and essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. The target 3.8 under the SDGs is achieving universal health coverage, and there are two indicators on how countries, it is recommended that countries measure progress towards universal health coverage. The two sub-indicators are coverage of essential health services and the indicator on financial protection. So in terms of monitoring health coverage, it's these two areas that I will spend the rest of the presentation focusing on. I know you're all sick and tired of seeing this cube, but unfortunately, again, in order to understand how best to monitor universal health coverage, it's important to remind ourselves that universal health coverage has three different dimensions. It's what proportion of your population is covered by prepaid pooled sources, what services are included in the benefits that are promised under prepaid pooled sources, and what proportion of financing comes from prepaid pooled sources versus direct out-of-pocket payments at the point of seeking care. So in order to sort of to add a little bit value here, let me point out that there are some things that are also wrong in this cube or are missing in this cube. First of all, the point here, the blue part is prepaid pool financing. So this is not government financing alone, right? Prepaid pool financing can be government financing, it can be financing from social health insurance, it can also be financing from private insurance. So prepaid pool financing is everything that's not out of pocket. So often there's a misunderstanding that prepaid pool financing is only government financing. Conceptually, no, it refers to all sorts of prepaid pool financing. The second sort of misunderstanding or slight problem in this cube is that if you look at the outer cube, that's referring to total health expenditure. And in many low-income countries, and also in some lower middle-income countries, some people don't seek care because they cannot afford to seek care. So if they're not spending on total health expenditure, this whole cube is missing those people. You can imagine that this can be a key missing link that you also want under universal health coverage to bring in. Those are foregoing care because they're too poor to utilize, are not incorporated here. So this cube was actually developed in reference to European countries, and you know, that's one reason why this part was missed out. And it is a big issue in countries like Laos, PDR, and India, where a lot of people just simply forego care because they can't afford it. So that part is missing here. The third part that's missing in this cube is there's no reference to quality of care. So it just talks about service coverage, but it doesn't talk about how effective that service coverage is. And again, this is things that have been discussed. So it's also important to remember that this is a good conceptual framework within which to think about it. But if you're thinking of developing monitoring UHC indicators, some of these deficiencies in what the cube captures have also to be taken into account. So I'm going to spend the rest of my presentation briefly overviewing a sort of a massive data collection and compilation exercise. It's as yet incomplete, and it's jointly conducted by both the WHO, Raymond, you probably know about this, and the World Bank. Recently there was a report issued on how do you monitor universal health coverage. It's still ongoing. They haven't been able to compile data from all the countries, but the idea was as a result of several consultations globally and talking to experts and so on and so forth, WHO and World Bank came together and said these are some recommended indicators that countries should look at when tracking access to essential health services and financial protection. In other words, this is the dashboard of indicators that you should look at when tracking coverage or monitoring universal health coverage to see how well your country is going. And if you note, this has both preventive, promotive interventions, things like antenatal care coverage, skilled birth attendance. Raymond, DPT-3 immunization is supposed to be an indicator of universal health coverage. Interestingly, they also included things like non-smoking rates. This is all done in negative terms so that higher numbers are always better. So that's why it's non-smoking rates. And also have included other sort of non-health system determinants like access to improved water and sanitation, because they're key in terms of determining the risk factors that people face in falling ill. It also includes treatment indicators, including antiretroviral therapy coverage, hypertension treatment, TB treatment coverage, and also, you know, to add on some NCDs which were also not in the MDGs, diabetes treatment coverage. So these are also recommended treatment indicators to be tracked and monitored along with the preventive, promotive interventions. And then there's the third sort of recommended set of indicators that is related to financial protection. And several speakers earlier in this conference and in the panel spoke about this, but I'll just reiterate what we mean. The basic idea here is that people shouldn't face undue financial hardship when they seek health care. So you should be protected from high levels of out-of-pocket spending. And there are basically two indicators when monitoring universal health coverage when we look at this financial protection aspect of universal health coverage. So basically, one way to think about it is the two are catastrophic incidents of catastrophic payments and impoverishing expenditures. And what do I mean by catastrophic payments? Basically, one way to think about it is this is basically the cumulative distribution of households. And on the y-axis is consumption expenditure, which is comprised of both medical out-of-pocket spending and non-medical out-of-pocket spending. So catastrophic expenditure is being defined under the SDG framework by the WHO and World Bank as if medical expenditure is more than 25% of consumption expenditure. And Darren, you use 10%. I think there's been some debate and they've come to 25% as being sort of an intermediate number. So one way to assess financial protection is to see how many households are having out-of-pocket health spending more than 25% of your consumption expenditure. That's considered to be a bad thing because it takes away from more productive consumption expenditure on other things that are much more desirable. So if you look over here, this is a household that's above the poverty line and is having expenditure that's less than 25% of consumption expenditure on out-of-pocket health spending. So this would be considered non-catastrophic out-of-pocket expenditure. And then the second bit of expenditure is impoverishing expenditure. This is the expenditure that pushes you below the poverty line. So this is the second sort of aspect of financial protection, saying that you want to also look at the extent to which out-of-pocket health spending is making you poor or pushing you deeper into poverty. So in this case, the 25% is not the focus. The focus is whatever out-of-pocket health spending you're having, whether it's pushing you below the poverty line. So here are sort of two examples. These are so the catastrophic one over here is anything greater than 25%, and impoverishing will be expenditure that pushes you below the poverty line. So if you do a before and after, if you take out the out-of-pocket health spending and see whether you're pushed below the poverty line, and here it can be less than 25%, by the way. So this does not have to do with the 25% threshold. Any expenditure, even 2% that pushes you below the poverty line, is considered to be impoverishing. And of course, any health expenditure incurred by the poor is also considered impoverishing because it's pushing you deeper into poverty. And this is actually very relevant. This distinction is extremely relevant for countries such as Indonesia, where a large share of the population is actually heaped just above the poverty line. So even small amounts of out-of-pocket health spending can impoverish people and push them below the poverty line. And I'm happy to explain more offline if people want to understand this a little bit better. But this is how that third bit of financial protection indicator has been conceptualized in terms of recommending how you monitor universal health coverage. So the share of the population that's facing catastrophic spending, as well as the proportion of the population that's being impoverished or being pushed deeper into poverty, are two sub-indicators under that measure. The rest of the presentation, I'm just going to present some results from this global exercise. I said it's as yet incomplete. We are still in the process of compiling data from everywhere. So these are data that are currently available. It's from a lot of low and low middle income countries, but not all are currently represented. The point here is that more people, this is showing you basically some of those health interventions that were noted in the dashboard of UHC indicators, how they've changed globally from 2000 to 2014 or 15 when we had the data, and this is looking at data among developing countries only. And I think the things to note is there's been steady and stable progress globally on several of these essential health services coverage. Notably, some of the biggest improvements have come in coverage of things that were very low in 2000, like tuberculosis treatment, antiretroviral therapy treatment. They've all increased significantly. Also, some of the MCH services have been steadily going up. But also notable is that very few of them, if you take the global average, are above 80%. If you think of 80% as the sort of the threshold above which you want to be as a result of saying that you're closer to universal health coverage, except for the access to improved water, and almost none of them are close to 100%. So this is sort of a big picture global view of what low, lower middle and upper middle countries are with regard to access to essential health services. The other point to note globally is not only are levels of access to these health services improving, but inequalities are narrowing. If you look at the concentration index, it's actually, things are becoming far more pro-poor, so the poor are benefiting at a higher rate than the rich in terms of access to some of these essential health services. However, as I noted earlier, we cannot forget that coverage is far from universal, and I'm calling XMDGs sort of the MCH and HIV, TB, malaria coverage indicators, and our estimates suggest that more than 400 people lack at least one of these 7 essential services that are noted over here. So this will include women whose demand for family planning is unmet. It includes pregnant women who have not received at least 4 antenatal care visits. It also includes children who should have been immunized and have not been immunized, and so on and so forth. So at least 400 people lack access to at least one of these 7 essential services that are included in the dashboard of indicators for measuring access to UHC. And the problem is particularly dire for NCDs. So, at least for XMDGs, we seem to be doing better than for NCDs. And what this is showing is results from, I think this is also a WHO survey, the STEPS survey. And this is showing people who had hypertension and were not aware. And it's also showing those who had hypertension but were not on medication. Those who had hypertension were on medication, but that's not controlled, and then those who were on medication and were controlled. And so this really is the one that we want to look at in terms of measuring effective coverage of some of these services. And there's a range of countries ranging from 7 to 61% coverage on hypertension treatment, but effective coverage rates are very low. They're ranging from 1% to 31%. And for those who are interested, again, this is split up by region. These details are there in the monitoring UHC report that is available online, or I can also give you a PDF copy of this. Also, let's not forget that substantial inequalities continue to persist, except for, I think, DPT3 coverage, where the inequalities are relatively low if you sort of look at the global data. But for antenatal care, for skilled birth attendants, and what is that one? And sanitation, the inequalities are significant in that the access that the poorest quintile has is far, far lower than that of the richest quintile. So, that's one way to disaggregate looking at what's happening to the data globally. Similarly, for NCDs, in some countries, the average levels of treatment for hypertension remain low, and there are inequalities. But if you look at countries like Peru and Egypt and Bangladesh, several of them, the inequalities in coverage of things like hypertension remains significant, and also the levels remain relatively low. And of course, global averages always mask sub-regional variations. If you compare, so this is basically showing what happens from the baseline of 2000 to end line of 2013. If you look at high-income OECD countries, they're almost close to 100% on all tracer indicators, except for perhaps TB treatment. And this is these are the countries you can use as benchmark to say, when you're close to, these are the countries that we consider closest to being to UHC. And you can see that sub-Saharan Africa is the region that's lagging the most. I think except for DPT immunization, that's heading towards 80%. There are big deficiencies in several of these other indicators, and I think South Asia is the second biggest lagging region. And if I remember the data correctly, I think that 2/3 of the global unmet need across these UHC tracer indicators is actually from these 2 regions alone, which represent, I think, about 1/3 of the global population. The other regions, they're masking a lot of variations, and progress tends to be good in some areas and not so good in other areas. East Asia and Pacific does, for instance, well in family planning, skilled birth attendance, immunization, but less well in antiretroviral treatment and 4 or more antenatal care visits. Now moving away from this very big global thing, like I said, this is still ongoing, and in some cases I think the Indonesia data has not yet been incorporated into the global database, but it is in the process of doing so. This is just looking at these same indicators and comparing Indonesia to the BRICS countries, the BRICS meaning Brazil, China, India, Russia, and South Africa, as well as some regional comparators. And in terms of coverage of these preventive promotive indicators, I think the evidence is a bit mixed. Indonesia has done well in some cases and has a lot more to go in others. The red are those that are below 80%, so just to show where the deficiencies are. So Indonesia's still below 80% in access to family planning, but it's higher than the average for East Asia Pacific and for lower middle income countries. It's doing relatively well in terms of ANC. This is at least one ANC visit, and relatively higher, and also in terms of skilled birth attendance, relatively higher than the regional average and to comparators, but needs to do much better in terms of DPT-3, and I think this was also something that Raymond had mentioned. Immunization rates are lower than its peers as well as the average for the region and for lower middle income countries. Tobacco non-use is really an outlier. I think only Russia is worse than Indonesia, so this is sort of an area that should be a focus, and similarly for water and sanitation. Some other tracers on treatment for ARV, Indonesia is quite low. For TB, it seems to be doing relatively well. And also in terms of financial protection, Indonesia's share of out-of-pocket spending, and the flip side is the share that's prepaid pool financing, is still relatively low. In terms of the out-of-pocket spending share, that's more than 25%. Only 1% of the population tends to have catastrophic health expenditure, but the impoverishing effect is relatively high. And this is sort of relatively older data, but this is the newer numbers that have come in. And you can actually see that about this is ECHO 2015 data, right? We just did this. So about 1 million households, or 2% of the population every year, are impoverished. That means pushed into poverty as a result of out-of-pocket spending. About 1% of households face catastrophic health expenditures. As I noted earlier, this is expenditures more than 25% of consumption. And about 4 million poor households, about 6% of the population, is pushed deeper into poverty as a result of out-of-pocket health spending. So still a long way to go in terms of improving financial protection. And this left-hand graph is basically showing that out-of-pocket spending in Indonesia is actually a little bit progressive, in that the richer deciles tend to spend a higher share of their consumption expenditure that goes to out-of-pocket spending, because usually out-of-pocket spending tends to be regressive. In Indonesia's case, it's slightly progressive, and a huge share of out-of-pocket spending is actually in the first two top deciles. So almost 40% of all out-of-pocket spending in the country actually can be attributed to the richest decile. And again, I'm happy to talk to people after this to give you or talk you through details. One other thing that we did was we just put all the UHC dashboard indicators and made an index across countries. And here you can see this UHC Attainment Index, which is just converting all those indicators that I pointed out and combining them into one indicator. And on the x-axis is GNI per capita, and I don't know if you can see this, but these are the low income, lower middle income, upper middle income, and high income countries. Indonesia is at the cusp of becoming upper middle income country, and its UHC attainment is below what might be expected for its income level. And I think it's also notable that you actually look this way, and you can see that countries such as Cambodia and Solomon Islands and Vietnam, that are far poorer than Indonesia, actually have better UHC attainment indicators. So in that sense, I think Indonesia could do a lot better in terms of making improvements towards universal health coverage. So I'm going to just end with this slide, just key takeaway messages. People always complain that my presentations have too much data and too many things, so I'm just going to summarize some key points that you should take away. To remind you that UHC has 3 dimensions. It's about the number of people covered, it's about service coverage, and it's about financial protection. The second box is very important, because every time I see presentations, especially from MOH and all, they are measuring progress by the number of JKN cards distributed. That's not a good measure of universal health coverage. In many ways, universal health doesn't even matter how you finance UHC. It could be tax finance, social health insurance, what have you. It's really important to look at what's happening to health service coverage and financial protection, not the number of JKN cards distributed. UHC is really about ensuring both effective coverage and financial protection, not the number of cards distributed. And globally, as you can see, there has been a lot of progress on these ex-MDG indicators. However, inequalities remain, and also globally NCDs coverage remains weak, including in Indonesia. So I think that has to be sort of a next phase of focus. The final point is Indonesia needs to make more progress on several of these indicators of UHC, including family planning, sanitation, tobacco, immunization, NCDs, and needs to reduce out-of-pocket spending on health in order to make real progress towards universal health coverage. And finally, my final slide is just to remind you that it's not just UHC that's an SDG indicator. There remain SDG indicators that are related to more population health outcomes. So one should not only look at UHC index or access, but also look at it in conjunction with what's happening to your population health outcome indicators. Indonesia did well in terms of reaching the under 5 mortality MDG, and but it didn't do well. It didn't reach the maternal mortality MDG, and the SDG indicators for these are 70 for maternal mortality ratio, 25 for under 5 mortality and neonatal. So Indonesia needs to accelerate progress, in particular for maternal mortality, in order to reach the SDG target of 70 by 2030. And again, this, I remind you back that the stillbirth attendance and antenatal care coverage was quite high in Indonesia, so it's suggesting that there are issues with regard to quality of antenatal care and stillbirth attendance that needs to be addressed. That's why it's important to look at both the coverage of these indicators as well as final population health outcomes. Okay. So I will end now. Thanks very much.